A single puncture is all it takes. A mosquito bite becomes the entry point for two of the world's most dangerous fevers. The human immune system is highly sophisticated, yet it often responds to both a fast-replicating virus and a burrowing parasite with the same physiological signal, a sudden spiking fever. Misinterpreting that signal has severe clinical consequences. Treating a patient for the wrong illness gives the true pathogen time to multiply, allowing internal bleeding or organ failure to progress entirely unchecked. The threat begins with two distinct factors. On the left is the Aedes mosquito, an urban daytime biter. On the right, resting at a sharp upward angle, is the Anopheles mosquito, which primarily hunts in rural environments after dusk. Despite their different origins, the early infections they cause mirror each other. A patient will typically present with high fever, severe headaches, deep body aches, and overwhelming fatigue. Because these physical sensations are so intense, many patients and practitioners assume they can identify the specific disease just by observing how the fever presents. But attempting to treat a severe fever based purely on outward signs ignores the microscopic biology at work. It turns manageable medical care into a guessing game with high stakes. If the Aedes mosquito strikes, the invader is dengue. This fast-replicating virus binds and melts directly into host immune cells to hijack them for multiplication. As the viral load surges, the body mounts a profound inflammatory response. This internal inflammation triggers dengue's trademark symptoms: intense pain behind the eyes and severe aching in the muscles and joints. In severe dengue, the density of platelets drops sharply. As they vanish, vessel walls become compromised. Fluid escapes the circulatory system, pooling in surrounding tissues. This loss of blood volume leads to a dangerous drop in blood pressure and physiological shock. Modern medicine has no direct antiviral drug to stop this process in routine cases. Physicians must provide supportive care and closely monitor fluid levels while the patient's immune system fights off the virus. Dengue does not typically kill by destroying organs directly. Instead, it triggers a systemic fluid leakage that causes the circulatory system to collapse from the inside out. The Anopheles mosquito delivers an entirely different threat, a Plasmodium parasite. These parasites aggressively invade red blood cells to multiply. Once mature, they forcefully burst out of the cells, flooding the bloodstream to infect new ones. This synchronized destruction of red blood cells dictates how malaria presents in the clinic. The sudden cellular rupture causes violent chills, profound sweating, and the rapid onset of anemia. In severe strains, the infection makes red blood cells sticky and rigid. They clump together, creating physical blockages in capillaries. Zooming out, these blockages choke off oxygen to major organs. Areas turning dark indicate tissue damage, leading to cerebral malaria and acute kidney failure. Malaria is a mechanical and parasitic destruction of the body's oxygen delivery network. Unlike dengue, it requires immediate, targeted chemical intervention to halt the parasite's life cycle. In a clinical setting, a patient arrives with a high fever and sudden, violent chills. The outward symptoms point in multiple directions at once. A common assumption suggests that if a blood panel shows a rapidly dropping platelet count, the patient must have dengue. This chart illustrates why that assumption is unreliable. As the platelet count drops into the red danger zone under dengue, it does the exact same thing under malaria. Severe parasitic infections can destroy platelets just as aggressively as viral ones. The reverse is equally deceptive. Relying on heavy chills as proof of malaria ignores that other intense infections trigger the exact same physical response. Relying on symptom-based diagnoses for these overlapping diseases is essentially a coin toss. When organs are failing or plasma is leaking, a guess is not a strategy. Beyond symptoms, there is only one objective way to distinguish these diseases: targeted laboratory testing. To identify malaria, laboratory technicians look for the physical invader. A microscopic blood smear or a rapid diagnostic test can reveal these distinct, ring-shaped purple Plasmodium parasites hiding inside red blood cells. Dengue requires a different approach. Because the virus is too small to see on a standard slide, clinics use tests calibrated to detect specific viral antigens or the body's immune antibodies. This flowchart shows the divergence in care once a diagnosis is confirmed. A confirmed parasite requires anti-malarial medications to kill the organism. A confirmed virus requires fluid resuscitation to counteract vascular leakage. Any high fever following mosquito exposure requires urgent medical evaluation, especially if the fever is accompanied by confusion, bleeding, or difficulty breathing. A viral vascular leak and a parasitic cellular invasion require entirely different responses. Only a definitive blood test can dictate the necessary treatment.